Good afternoon, everyone. It's just past 4 o'clock on the first Tuesday of March of 2021. So it's time for another NASCI Curious Cases webinar. So thank you all of you for joining us. It's good to see some familiar names on the list and some new people joining us today. So again, thanks for joining. As usual, this is a friendly group, a friendly discussion. We're here to share knowledge and to learn from each other. So if I know that some of you probably have some cases ready to present. So if anybody wants to start, and let me know, and I'll make you the presenter. Who said yes?
Sure, I can go first. Sandeep here.
Hey, Sandeep. Thanks for coming, buddy. Let me make you the presenter. All right. So you should get now a window asking you to accept, and then you can go.
All right. Can everybody see the screen okay?
Yes. Looks great. Thank you.
Okay, great. Let me pull up my presentation. So thank you all for joining. I have two cases to share. Case one is a 28-year-old man who presented with chest pain with a clinical diagnosis of pericarditis or myocarditis. And here are some SSFP short axis images. Next to it is a post-contrast T1 weighted image. And on these images, you notice that there is a finding which is along the inferior aspect of the right ventricle. The finding is of a susceptibility artifact that you would see as if there was some metallic element. The second finding that I wanted to draw your attention to is if you look at the pericardium looks thickened, and on the post-contrast T1 weighted image, you can see that the pericardium is enhancing. So no doubt this patient does have pericarditis. We also see some LGE images here, and on these images, you are much more convinced about the circumferential thickened pericardium, which is enhancing. We see some superior as well as inferior RV insertion hinge point LGE, which can be non-specific, and then we again see the artifact. And looking at this all together, we know that we are leaning towards the diagnosis of pericarditis and a susceptibility artifact likely resulting from some metal. But if you were at a workstation where you have ability to pull up all the prior exams, in doing so, this is the chest X-ray that we pulled up and really didn't have any metal there. This is an atypical spot for any pacemaker leads or any porticats to be at this particular location along the inferior aspect of the RV. So that kind of triggered our curiosity a little bit more, and we started digging deeper into what is available for us on PACS, as well as into the patient's history, which subsequently I will reveal the answer in a second, but in digging into priors, we noticed that the patient had a same-day abdominal CT for epigastric pain, and here are some abdominal CT images, and here you can probably appreciate this very linear hyperdense structure here, redemonstration of thickened pericardium along the anterior aspect here. And here is a curved planar reformat, MPR view of that hyperdensity. So in all, putting this all together, one history that we were looking for is this patient having history of IVTU, so which this patient did have. And upon recalling of the finding, the clinician went back and asked the patient more carefully about IVTU use and whether they lost a needle recently, to which the patient agreed, and they did lose a needle recently, but they thought it wouldn't matter. And that's the highlight of this case, that we have to look carefully. Some of these needles can be very, very small. Here are two images of baseline as well as 6 months transthoracic echocardiogram done in the short axis plane, and you can see that the needle fragment is very, very subtle and it's very small on echo, but as perhaps a little bit better seen on a 6-month follow-up echo. So in all, the diagnosis was a migrated needle in the RV in setting of IV drug use. We are seeing increasing number of IVDU cases, so it is important to screen for cardiac as well as extracardiac needle fragments, in addition to all the typical infective endocarditis, septic emboli, or visceral organ infarcts that we usually see. The importance of recognizing this finding is that they can be nidus for further infection. Surgery was offered for our case, but the patient declined, and it was conservatively treated with aspiration of hemorrhagic pericardial effusion and medication like ibuprofen and colchicine. I can stop there and see if people have any questions, and then in a minute or so we can move on to the case number 2.
Hey, Sandeep, so you couldn't see it on the X-ray? Even going back retrospectively on the chest X-ray?
Yeah, we couldn't see it on the X-ray. I can show the X-ray again.
Wow, interesting.
All right, let's do case number 2. If you have interest in vascular imaging and willing to travel further down south into the belly, this case is for you. This is an adult in his 60s with fever, abdominal pain, and lower extremity pain. And this is an axial stack of the CT of the abdomen and pelvis. And I'm gonna let it run once to allow you to pick up some of the findings here. And as it comes back up, I'll walk you through the findings. So first off, the contrast is not great here. So this is a mixed arterial venous phase. You can see that there is a outpouching coming from the anterior aspect of the aorta. There is peripheral hyperdensity right next to it. Kidney is not looking great either. There is an IVC filter. And as you go further down, you see no contrast in the right common iliac as well as right external iliac artery, which then gradually does not actually fill all the way until it becomes the common femoral artery. So this was diagnosed as a mycotic pseudoaneurysm. We all know that Staphylococcus and Streptococcus are the two most causative organisms that are common culprits for these. Most frequently involved visceral artery in mycotic pseudoaneurysms is superior mesenteric artery, so look carefully for pseudoaneurysms of that artery. And synchronous or metachronous involvement can occur in up to 36% of the cases. Upon making this call, the patient was taken to the OR, and here is post-operative CTA, where we have a little bit better opacification of the aorta. And in doing the surgery, they had to extensively repair the visceral origins because the pseudoaneurysm involved the wall of the aorta, and the wall was weak, so they had to reimplant all the mesenteric as well as left renal vessels. They could not salvage the right kidney, and you can see that the right kidney is not enhancing here, but they were able to restore the flow to the right lower extremity. And I'm gonna go forward scrolling here to show you that there is now flow in the right lower extremity. And the resected specimen of the upper abdominal aorta was sent for pathological as well as microbiological examination. And final diagnosis here came back as capnocytophaga. So capnocytophaga is a atypical infection that can lead to formation of pseudoaneurysms. We believe these are gram-negative bacterial infections, and these can typically travel from, say, a pet. So no offense to all the dog lovers out there. one of the things that predisposes people to get infected with capnocytophaga is immunocompromised status, which we did look for in the history. The patient did not have it, and the spleen was also present and normal sized at the time of the initial CT. So just an interesting case. I thought I'll share that with the group and pause here for questions. And thank you for your attention.
Thanks, Sandeep. Those were great cases. Any questions from anyone?
Hi, Sandeep. This is Ayaz from Brigham Women's Hospital. Quick question. It's a nomenclature question, just to reiterate. Do you call it mycotic aneurysm or mycotic pseudoaneurysm?
Well, we use the term mycotic pseudoaneurysm when we can.
Yeah. I mean, I used to call that way, but then we had a kind of like similar case and we discussed our surgeon. And then all the vascular and cardiac surgeons came to me like, don't call it pseudoaneurysm, it's mycotic aneurysm, because they freaked out the term of the pseudoaneurysm. That's why I was trying to, learn a little bit more this nomenclature about these.
I'm curious to
cases,
see thank you. I'm curious to see what others opine on about their terminology that they use. But I think the bottom line is that the affected vessel has a weakened wall as a result of infection. So it is prone for early rupture. And that's why this kind of finding needs an urgent attention.
Yeah, I totally agree.
Any comments from anybody else?
I agree, they're pseudoaneurysms, they're not aneurysms.
Yeah, that's Joan. Yeah, but I agree that I also call them pseudoaneurysms, and I've never had a surgeon freak out at me for calling them that I can recall. All right. Anybody else wants to show cases? Thanks so much, Sandeep.
No problem.
Who's going next, guys? Before I volunteer someone.
I can show a case if nobody else is coming up right now. This is Prachi here.
Yes, Prachi. Let me make you presenter. Yeah, I also have a few cases if nobody else has any, but I want to give everybody a chance first. So you should get a window to accept now to be the presenter. There you go. We can see your screen.
Okay. So hopefully this works. This was a middle-aged female and came in for a PECT. And I'll let it run first. So of course, you're already seeing the aortic abnormality. Now, as you come, look at the pulmonary arteries. It's got a very differential attenuation with much lower opacification of the right versus the left. I'll play it one more time just so that you guys can see it. And if anybody has any opinion at this point, feel free to chime in.
Hey, Prachi, this is Sandeep here. Is the patient infected at this point of time?
No, there was no such history of infection. It was just like the usual shortness of breath, that kind of stuff.
Okay. I would really love to see an MPR view of this outpouching and whether that is communicating with the PA where there is a differential opacification.
Excellent. So the MPR view was very interesting. And hopefully this will clarify some of the stuff you were talking about. So here is that aortic outpouching. It had this communication with the pulmonary artery. And very interestingly, it had dissected the pulmonary artery. So now you had a false lumen And as you can see, let me play this axial images once more for you. Okay. So let's try playing this. So you can see that the opacification, because it was timed for the pulmonary artery, was much better opacification of the RV. And this was the true lumen. So now if you see, this is the aortic opacification, and this is what communicates with the right pulmonary artery. So this is the false lumen, which was extending into the right pulmonary artery. The left predominantly had this true luminal communication with the main pulmonary artery and RV. So it was interesting because I hadn't seen pulmonary artery dissection before. And it's hard to appreciate this on axial images, but sagittal, it really provides a very clear appearance of that flap. Now, this patient, ultimately, they had to do extensive surgery. The patient was not in a very good condition, so they attempted endograft placement in the aorta, primarily for that outpouching in the aortic arch. And they also placed an Amplatzer device. But unfortunately, you can see it didn't really work very well. So we still had that outpouching, and it was an extremely tortuous aorta, which is why they could not really get a good closure. And you can see that, again, the aorta opacification matches the RPA, and the main and the RV kind of, it matches the LPA. So this was a pulmonary artery dissection. Presumably, it was an aortic aneurysm, started off as an aortic aneurysm, which leaked and dissected the MPA later on. Unfortunately, the patient had a very bad outcome and was deceased. But I'd never seen a pulmonary artery dissection, so just wanted to share it with the group.
It's a pretty great case.
Any comments? Anybody seen pulmonary artery dissection? Just curious.
I've seen two. This is Phil Young. One I missed early in my career in a Marfan patient, and heard about that. And one we actually had about a week ago.
Oh, really?
A great case. It was beautiful, absolutely beautiful.
I'd love to see that. Maybe next time you should show that case.
Yeah, definitely, Phil.
Sure.
Yeah, Prachi, this is Joan. That was an amazing case. Yeah, we had one. I'll get it ready for next time too. It was someone who had a ruptured type A aortic dissection and basically dissected the pulmonary artery and completely occluded the right and left pulmonary arteries because it was just completely compressed by the false lumen. He was pretty wild case. He died also.
Maybe we need to put these cases together and publish them.
You have a
That's
series,
actually a really good thought.
Prachi, there's a question on the chat board from Dan Vargas. I don't know if his microphone's not working because Danny usually is not shy to ask.
This is a very, yeah.
But he's wondering if there's a ductus diverticulum associated with this. In some images, it kind of your MPRs kind of looked like it. There may be one.
So I don't think this is just related to a ductus. I mean, this is an aneurysm of the aorta for sure. It is in the region of the ductus, but I think its angles and everything does not really look like a ductus. But really, I mean, how long this patient had this, what came first is hard to explain. Yeah. Really hard to know. But our thought and the thought of the treating team was that it was a big sacral aortic aneurysm that had ruptured into the PA and dissected it.
Great case. Thanks for sharing. Really, really great case. And it seems like next month we're going to see at least 2 more of these.
Yeah.
There's another quick note here on the chat. Says the reason I mentioned it is from Dan, because usually ductal tissue is weaker than the aortic tissue. Fantastic case. So yes.
Okay. Excellent. Thanks, Dan.
Perfect. All right. Thank you, guys. Who's next?
I can show a couple. This is Phil Young.
That's Phil. Yeah. All right, Phil. You have a tough act to follow.
No. All right.
Yes, we can see it.
I was going to show a couple of kind of post-op type or operative type cases, put it that way. So the first is a 55-year-old female. She's seen for evaluation and treatment of recurrent pericardial effusions in the setting of seronegative rheumatoid arthritis. Has a history of coronary disease and has had several angiograms. Most recently, April 2019. I read this case last week, so it's a fresh case. This case demonstrates patent stents. She had recurrent pericardial effusions. In February, she had a drainage. The 3rd, April 23rd is negative. Pericardial vascular.
We're losing you a little bit, Phil. So
subsequent CT. You're missing me, you say?
Yeah, you're breaking up a little bit. Just, I guess, speak a bit slower, see if we can catch much of the phrases. If not,
basically, CT, and you refer to us. So this is right here. This is the sinoatrial nodal artery coming back here to this vascular mass back here. And this is her outside CT, where you can see there's a very bright mass along the posterior atrial wall, sort of between the atrial septum and the crista terminalis. And here's a pericardial effusion. Is this projecting okay?
yes.
All right. So in our practice, what I wanted to highlight for this case is the value of cardiac CT, because most people think cardiac MR is the go-to for cardiac mass imaging. We almost really like CT. And it's not hard to do, in part because, I mean, it's almost inconceivable that a patient with a mass in their heart doesn't deserve a CT of the chest, abdomen, and pelvis to look for a primary tumor. CT of your chest, get as much information you can, especially about things like relationship to adjacent structures, coronaries, valves, and the resolution and volumetric coverage of CT are unparalleled. One of the issues is that the coronary angiographic phase often doesn't optimally depict the perfusion of perfusion. So we do a CTA and then an immediate dual energy delay that takes place about 20 seconds later. And you see how much in the time this hypervascular mass has perfused between the coronary CTA phase and delay phase. And of course, get virtual non-cons from that. You can look at calcification. This is a sort of overlaying the iodine images with source images kind of showing the perfusion of hypervascular mass, as you can see here. Notice it's very well circumscribed, not really aggressive looking, but it has increased in size in the last 2 years. And in fact, if you note that you could see this on the coronary angiogram, the patient had several prior coronary angiograms where you can see this thing slowly growing over at least 6 years. So this is a relatively hypervascular, well circumscribed, slowly growing mass. No volunteers. This was a really good look. They all look like this. They're really hypervascular. They're really well circumscribed. They are fairly slow growing. And so what we did was then it was a gallium 68 PET CT. Which is for receptors on these tumors. In fact, some of these patients have an SDH mutation, and they'll get tumors and pheochromatoma. The other thing we said, to note, and these tumors shell out, but don't look aggressive, but they're very insinuate into a to develop, cut around this tumor. So there's a very high little dysfunction after surgery, anticipating what they're going to have to when they go in here. You know, it doesn't look like this sort of dual energy approach and multi-phase really helps to distinguish, for example, what you see here, much more aggressive, much more enhancing. Oh, okay, so I just got a note. So I'm so sorry, it's hard to hear. This is an angiosarcoma that actually ruptured into the pericardial space on CT. There are tumor nodules here throughout the pericardial space, which is probably what's containing this rupture and the reason the patient didn't, you know, actively, you know, crump when this ruptured. Let's skip through this case since people are having trouble hearing me, but if one can hear me, this is a case I show to all the trainees. And this son who had a spinal resected many years previously, had high-dose radiation, had significant valve disease, and so needed aortic and mitral valve replacements pretty deep. What nobody talked about is how there's no fat between the sternum and the aorta here. Damage in post-surgical tissue. When they did the sternotomy and put in the rib spreaders, it's all just ruptured all the way down. The patient exsanguinated right there on the table. It's really, and if bypass before we crack the chest. So I always tell our trainees to look out for this kind of stuff. Here's a recent case we had with the off right in the aorta. It's actually, you know, coming down from above, but it's deviated and all scarred in. It's not fat. This is all scar tissue. And despite the fact that they did put the patient on groin bypass, they still damaged it during the I think this is a 4th time sternotomy. Someone who had a Lima to LAD bypass graft, never really got better, had persistent shortness of breath, the ED. And what you'll see here is they first had a non and then had a PE study in which they injected from the left arm. And what you see here is all this hyperperfusion of the LAD territory, injection on a PE study. And it turns out that what happened was that an outside surgeon had inadvertently bypassed, instead of doing a Lima to LAD, they had inadvertently harvested the left internal mammary vein and used that for bypass. And so what you see here is direct, venous contrast perfusing the LAD territory from the left internal mammary vein. The patient had a central venous stenosis, and you can actually see some collaterals here in the chest wall. When they injected through the left arm, directly went down to LIMV, retrograde into the LAD territory and perfused the pericardium. So those are my cases. I hope you could hear some of that. Sorry for the connection issue.
Thank you, Phil. So the great cases. Yeah, you were on and off a little bit on the audio. We'll try to fix it for the recording. I'll talk to you later about that. There's a question there from Joan. So the diagnosis of the first hypovascular mass by the SA nodal region was
paraganglioma.
Paraganglioma, right? And you did that's what you did gadopentate PET on that one. Great. This last case is wild, by the way. Perfect. Thank you so much, man. All right. Anybody else? Questions, comments? All right. Who wants to go next? Anybody has cases? No other cases, guys? Going once? Twice? All right. I have a couple that we can review. See if you can see my screen. All right. So I have 3 cases here. They're pretty quick, kind of show and tell only. Let's start with this one. For some reason, it seems like my image is paused on the viewer. Let me share it again. All right, here we go. So it's just a follow-up on a patient. I do not remember what the original indication was. This is not a necessarily a new case, but a couple of things you can tell here. It's the myocardium seems thickened, so this is a systolic phase. The patient had a TAVI in the past, and they were doing a TAVI protocol on this patient. I don't know exactly why, and you can see the valve there. And does anybody see anything there that's interesting or suspicious on that slice?
It's got halt.
Yeah, correct. So you can see here hypoattenuated leaflet thickening of one of the valves of the new valve. It's pretty classic, has that little concave shape to it. And once you see one, they all kind of look exactly the same. What changes is which one of the valves and the prosthesis, which one of the leaflets may be affected. I've never seen more than one leaflet at a time affected with halt yet. I've seen a few cases, but I'm sure that it may happen and you can get more than one, probably two. Most of these are found incidentally in patients, as they don't necessarily will create a gradient across the valve. Literature that I've seen quotes about an incidence of about just under 3%, 2 point something incidence for this. And this, one of the larger series that I saw, puts the patients at a slightly higher risk for TIAs and a smaller but also higher risk of strokes even when they show this. And there's a bit of controversy over the use of anticoagulation or not. I think most places, if the patient has no contraindication, will just put them on anticoagulation to try to dissolve that thrombus that's sitting there by the valve leaflet. So that's one case. Just something that I saw recently, and we don't see it that often, so I thought it was worth showing. But once you see one, you'll recognize them. Let's see this one next. So there is a tracheal bronchi here in the right upper lobe. It's better seen on the coronal images if this thing lets me show them to you. Okay, so we'll have to do reslicing. I don't know why it's not letting me look at those native images, but you see it right there coming out of the trachea. So what's interesting about this case is that there's also a very early right upper lobe pulmonary artery coming out of the right pulmonary artery, like almost at just past the bifurcation here, really, really early. So there's a variation of arterial anatomy in this patient with an anomalous, not anomalous, but a variant anatomy of the bronchial tree. So my question to you guys, because I was looking at the literature with one of my partners here, we didn't really find much on this, but have you seen these associations of tracheal bronchi with variations on the pulmonary arterial tree as well?
Hey, this is Joan. Interestingly enough, we have a paper in, hopefully gets accepted to it didn't get in a New England Journal, but it's a big paper with the vascular surgeons, multi-institutional, where we were using kind of the modified Miller approach to grade total thrombus in pulmonary emboli in people who were undergoing either ECOS catheter thrombolysis or standard thrombolysis. Anyway, one of the things that was interesting is that the none of the classification systems for grading thrombus burden are really any good, because none of them take into account how variant pulmonary arterial anatomy is. We actually, not necessarily in association with a tracheal bronchus, but we see a lot of times there's a lot of variation in the right upper lobe pulmonary arterial tree. A lot of times we'll see, you know, not a true truncus anterior, but combining two segments, and then you'll see accessory other vessels. So it's, you can have multiple things. Right middle lobe is another classic. There's often not a right middle lobe artery, but separate medial and lateral segmental things. So it's really variation is the rule that we found very few cases, and it was like 160, I think, something like that. PA CTAs we had reviewed, having to grade, you know, every branch on these suckers, and it was amazing to me how variant the anatomy was. So just for what it's worth.
Yeah, so it's probably just totally independent of the issue with the bronchus. Fair enough. All right, so that was the second quick case. I think I had another one. All right. So this is a CTA on a relatively young patient. I think female. I think she was 44, early 40s. Came to the ER with a typical chest pain. They did a calcium score followed by a CTA, and interestingly, we found this thing here by the apex. Well demarcated, low attenuation mass in the left ventricle. And this is what it looks on the CTA. Oh, it's not letting me load. Why is it not letting me load? More selective here. My computer is acting up today. All right, so here they are. So you see it here again in the apex, low attenuation. So again, just an incidental finding. It's what we're calling a lipoma. It looks well encapsulated. It's attached to the endocardium in the LV apex. Lipomas are relatively uncommon, but they do happen. They're about 10% of the primary cardiac masses. These are benign entities. So I think they're just going to observe this. I don't know if they're going to put the patient on any sort of anticoagulation for the chance of any thrombotic emboli or anything associated with this. Not I don't think that decision has been made last I checked the clinical notes. So just a cute little finding, incidental on this young patient. The coronaries look pretty clean on this atypical chest pain, young female. Any comments about this one?
Jacobo, Sandeep here. Was it mobile on the CT, or did you just had one phase?
Yeah, it was prospectively gated. I don't have moving images, and I don't think she has had an echo yet. If they're gonna do, which they will probably do, because they'll do it for other reasons, for less important reasons. They're definitely gonna do it for this.
Thank you.
All right, those are the 3 quick cases that I had. Anything else, guys? Anybody else has cases to share?
I can show 2 more, just quick show and tell.
Sure. All right, let me see. Let me make you presenter. Do you know the drill? You get to accept.
Yep. Give me 1 second. I know this is cardiovascular, supposed to be cardiovascular
Yeah,
seminar.
that's not a heart. That doesn't look like heart.
But I'm gonna tell you how the story unfolded. So this is a diffusion-weighted MRI of a middle-aged man who presented with stroke. You see the stroke there. There was a questionable history of atrial fibrillation, and one of the thoughts was whether the patient had a left atrial thrombus, and hence a cardiac CT was ordered. And here is a cardiac CT. So in here, you see a large polypoid, pretty much mobile mass that is attached to the lower aspect of the interatrial septum, very close to the aortic annulus, and it is prolapsing through the mitral valve into the left ventricle. And so differential here would be obviously common things being common. This definitely could be a thrombus given the attachment site to the interatrial septum. Myxoma is a good thought. Papillary fibroblastoma associated with mitral valve given its proximity to the mitral valve could be another differential. Those were top 3 of my choices, and I'm gonna pause there and get some thoughts, and then I'll tell you what the diagnosis is. Any thoughts? Anyone?
I can give you the differential, which you already know it.
Okay. So this was resected and came back as myxoma. So the point I wanted to make here is not all myxomas like to follow the same circular, very well-defined outer circumference. Some of the myxomas do have papillary frond-like projections on their surfaces, and those are the ones that can throw systemic emboli and result in stroke, such as in this case. My next case is.
Excuse me.
Sure.
I have a question. Have you ever seen such large papillary fibroelastoma?
Most of the papillary fibroblastomas that I have seen are nowhere more than 15 to 20 millimeter, and this is way bigger than.
Yeah. That's why I wonder, because all the papillary fibroelastoma that I have seen, they were all smaller, well defined, with well defined contours. So Okay,
Yeah.
thank you so much. Thank you.
No problem. So this is a coronary CT of a middle-aged man with dyspnea, and I'm gonna pause when the finding is displayed. Oops, sorry. Actually, I'm gonna let it run. I'll tell you off the top of my head, coronaries were pretty unremarkable. There was no obstructive coronary artery disease. I'll let it run one more time. And this is the finding. So there seems to be a vessel that is connecting between the connecting the LED to the main pulmonary artery. And really, if the only branches of the LED that are medial are septal branches, they should really go down towards the septum and should never join the PA. And that is a teaching point here. So this one did drain into the PA, and hence leading the diagnosis of coronary to PA fistula. The patient did undergo a coronary angiogram to confirm the diagnosis, and here is a picture of that vessel that is coming out from the LED and has a little outpouching at its tip where it drains into the pulmonary artery. I think that's all I had.
That was great. Thank you, Sandeep.
Mhm.
All right, guys. So last chance. We have a couple minutes for an extra case if anybody has one. All right, perfect. So with that, thank you guys for joining. Thank you for bringing cases, being a part of this. You know, start collecting for next month, and we'll see you. I hope to see you. Bring your friends, okay? Take care. Be well, everyone.
Thank you.
Bye. Thanks.
Thank you.
Thanks, Jacoba.
No,
Thanks, everyone.
thank you, guys. Take
All
care.
right, next time I'm bringing cases, I promise. Bye.
Bye.